Hello, everyone, and welcome to AdEchoTech's first ever international webinar from here at the historic and beautiful Château d'Amboise in France's Loire Valley. We're so happy that you could join us here today. My name is Charlie James, and I'm excited to introduce you to the work that AdEchoTech is doing to make high-quality ultrasound expertise available to patients anywhere. Their innovation is called Melody, and it's the world's first and only remote robotic ultrasound system. It's already FDA approved, and it's already being used to significantly improve care, access to care for people wherever they live, particularly in remote or underserved areas where a doctor might not always be available. So Melody is connecting patients who live in remote villages, in nursing homes, in prisons, with providers and specialists who may be hundreds or even thousands of miles away, and all while providing the high standard of care that they deserve. Now, let's be clear, this technology, it does not replace doctors. It extends their reach. It allows them to care for more patients while saving time and money and stress. So during this webinar, we're going to talk about how Melody is already being used, how it can help you provide more care for your patients. And then at the end, we're going to give you a chance to ask questions, your questions about Melody. So put your questions in the chat anytime during this discussion, and we will get to them soon. To give us a firsthand perspective on what it's like to use Melody and how it's changed their care, we have three world-class international doctors here with us today. First, we're joined by Dr. Ingrid Petrikke Olsen from Norway. She is a gynecologist who works directly with patients using Melody. So you will be providing hands-on experience and telling us about your hands-on experience with the technology. Great to have you here today.
Thank you. It's nice to be here.
And next we have Dr. Ivar Mendez. He is a neurosurgeon from Canada and the director of the Virtual Health Hub, which is transforming how healthcare is being delivered to Indigenous people in Saskatchewan. And Dr. Mendez, you've been involved with the Melody technology from the very beginning, so we're thrilled to have your perspective today.
It's wonderful to be here, Charlie.
And finally, we're honored to have Dr. Curtis Lowery with us today. Dr. Lowery is an OBGYN and maternal fetal medicine specialist in the U.S. state of Hawaii. Quite the journey that you have made. And you have significant experience bringing telehealth services to patients, including with the Veterans Affairs system in the U.S. Thanks for being here.
Yes, thanks for having us.
Each of you, you made this big trip. We really appreciate you sharing your time and expertise for this discussion. And Dr. Mendez, I'd like to begin with you because you've been involved with AdEchoTech from the early days, and through your leadership at the Virtual Health Hub, you've had a front row seat to the development of telehealth services as this has progressed. So I'd like you to just help us better understand the problem that Melody is trying to solve. Like, what did ultrasound access look like for your patients before?
Right. So, as you know, Canada is one of the largest countries in the world in terms of geographical extension. And we have a lot of population that live in the northern areas of Canada and rural areas. In the province where I work, Saskatchewan, which is the prairies in the middle of Canada, we have a territorial extension that is the size of France. But we only have 1.2 million people. And a lot of those people live in the northern locations, in the small communities. A lot of them are indigenous people. And one of the things that we grapple with was, how do we provide equitable access to care to these populations? These are populations that are truly underserved, that have the least and need the most. And one of the areas where we really focus our attention was in the high mortality rate for mothers and newborns in northern locations. We did a study in the province where we look at all the pregnancies for a period of 4 years, over 80,000 pregnancies. And what we found in this study was that, first of all, if you're an indigenous person, you have 50% less likelihood to have a prenatal ultrasound. If you live in a rural area, you have 30% less likelihood. And if you combine those two, you're an indigenous people that live in a rural area, you have 65% less likelihood to have a prenatal ultrasound. Therefore, you have poor prenatal care. So when we started looking at Melody, at a system that is a robotic system that can be manipulated and controlled from a centralized location, we found that that was a good potential tool to decrease this maternal and newborn mortality, to provide prenatal care to these individuals that otherwise will have to travel thousands of kilometers on their own, put in hotels, and get. Can you imagine your first prenatal ultrasound without your partner, without your family? So about 10 years ago, we started working with AdEchoTech, and we started really comparing, first of all, can a robotic ultrasonography system be comparable to the standard of care, an in-person ultrasound system? And what we found that they were quite comparable. So we started deploying this system, and now we have 7 locations in northern Canada where we provide telerobotic ultrasonography. So the patients don't have to travel to the cities. So we have timely care. We now do about more than 1,000 ultrasounds a year. So we found that this tool was really a tool that will narrow the gap of inequity, and specifically for the most vulnerable segments of the population. Those are the mothers and the newborn child.
Mhm. Were these the same challenges that you were seeing as well, Dr. Olsen and Dr. Lowery, or were there other different challenges that you experienced?
Now, in my area, I live in the Arctic, and also it's a low density of people, but it's very few patients that will not attend an prenatal ultrasound. But for instance, today, the weather is so bad, so there is no communication at all. And then, then if you had this, could apply this melody, then the weather, we would erase that question. But the main issue for us when we started with melody was to eliminate the distance and to give the healthcare service closer to where patients live. Avoid traveling, because as a woman, when you are pregnant and in your late pregnancy especially, it's bothersome to travel for several hours to have a quick ultrasound to see if your fetus is doing okay, and it will take the whole day. And it's also an economical question about staying away from home, from your family. You have to pick up in the kindergarten. You have to arrange in case you will not reach home again before. If you have a appointment after lunch, so it's when you have to travel 2 or 3 or 4 hours just to have an obstetric ultrasound. It's a lot of efforts and organizing you put into it. And when we have this technology, why not use it?
And what about for the providers, for the doctors? What are the challenges that you've seen with these communities that you've served?
Well, I've spent most of my career in academia, and it's a safe place to live because I have support for everything I need. In rural areas, that's not the case. They're out there by themselves, often trying to make decisions. It's been said that where you live might determine whether you live or die, and that's absolutely true. I think the idea here is that if we can make better diagnosis sooner and plan therapies faster, then we can save lives. So I think as we begin to deal with technology and healthcare, we can make a big difference, because really it's about our brains, right? Our intellectual properties, which make a big difference. I mean, I'm not saying surgery and devices don't really matter, but it's really about intellectual property and having the expert available whenever and wherever the patient needs it. And that's the key to this. So that's going to change everything, I think.
And Dr. Mendez, what kind of impact have you seen this technology have on your team? We know that there's a huge impact, obviously, on the patients who, for their time, money, stress, but What about for your team at the Virtual Health Hub?
Yeah. So I don't know, of course you have heard of this notion, moral injury, right? Moral injury is this sentiment as a healthcare provider that you have that you are not doing everything that you may or you need to do for your patient. So by decreasing the maternal and infant mortality, the personal satisfaction of the team that is in a centralized location to be able to provide that service to these individuals that may take 3 days to come to a center or may need to fly for several hours is of huge importance. It really makes the clinical team feel that what they're doing is what they train, what their devotion is to do as clinicians. Our product is the well-being of the patient, and so it has a huge positive effect on the team. And the other issue, which is I think important to mention, is the issue of the ethical imperative to provide care to the patients that need the most. It is an important thing to do that. They have to be up there. They have to be the priority. They cannot be receiving secondary or really not the top line of care. These people that live in locations where healthcare is very difficult to access deserve the best care. So this moral imperative, of course, has also tremendous impact on the providers, the healthcare team, which are physicians, which are radiologists, technologists, the engineers. The healthcare teams of the future are not only doctors and nurses, they are computer engineers, they are robotic engineers, they are AI specialists, they are computer specialists. So this is the whole multidisciplinary team. These are the teams of the future.
Dr. Olsen, I saw you nodding.
Yeah, I totally agree. And I also want to add in that in rural areas, the academic end, the scientific end, the group, the numbers that we do research on will never be a high number. But still we have the responsibility for giving them good health care. And because the group is so small and the university are all very often sited in the big cities, there is no one taking interest in these very rural people that also need to have health care, as you speak about, especially in Canada. I cannot say that in my area, in the very north of Norway and in the Scandinavia, is in the same serious situation, but still we have a responsibility to do the best. And if it's stressful for pregnant women to travel in bad weather and they are concerned about maybe I cannot come back in 2 days because it's a snowstorm arriving, so then we should use the melody system to reach them and to take the stress down. But also I want to say that it's necessary to do research, even though the end will never be a large number.
Well, it does provide the opportunity to include these patients in clinical trials. I mean, it's really expensive to do clinical trials because you have to have research nurses to recruit the patients, you have to follow the patients. But using technology now, the opportunity to include these rural patients in these trials, which now begins to reflect the population at large. Most of the trials we do in the world over, certainly in America, is in urban centers, and that doesn't represent the whole population.
No.
And particularly in indigenous populations, these groups are commonly left out of clinical trials, and that's very, very unfortunate because they have their own unique needs that are due to the, just genetic differences, but also socioeconomic differences from where they live. So it does provide a sort of a connectivity now as we begin to build kind of connected healthcare networks where we're sharing information, we're working more collaboratively with one another rather than, you know, traditionally academia has been get the patient here and I'll save their damn life, but then don't talk to me until you get them here, and that's unfortunate, you know. So I hope that this stuff will begin to change that, because now we're building functional networks to do these sort of things.
It's an opportunity to raise the end, even for the researchers sitting in the urban placed.
Yeah. So maybe I just should add something here that is really important from what the discussion. The first issue is that, of course, what technology does, it decreases distances. So we're going where the patient is, regardless of the geographical location. But it's particularly relevant now because of what Curtis is saying. These patients are often not included in these main studies. And with the advent of AI training data sets are mainly from big urban cities. Therefore, they can produce a bias that will influence the outcome of AI tools that will, instead of decreasing this gap of healthcare, may increase it and be disadvantages for these rural and indigenous and marginalized populations. So the inclusion of these populations is absolutely crucial, and I think technology will help with that.
Yeah, the AI training, it's only as good as the training set that you're using.
Correct. Yes.
And if that training set changes, then you have to retrain it. So that's the thing that we forget. That
Really important point there. I want to ask, when you think about your experience with Melody and the remote ultrasound technology, is there a specific case, a specific patient that sticks in your mind as someone that you were able to really improve their care, to even save their lives because of this technology?
Yes, I remember one boy, a teenager boy, who has pain in his testicles, and we had not rigged the Melody to do anything else than obstetric ultrasound. We used it in that specific situation because it was a testis torsion, and it means that you have to go to the hospital immediately. You have no. You have a limit time to save the testicle for this little boy. So we used it at that remote location, and we saw that the blood supply was very poor, and then we had to choose the transport. That was the fastest way to the hospital, and the hospital was ready. And he went straight into the operating theater.
So it was able to save
So we saved it.
time.
Yeah, and this was totally out of protocol. There was no guidelines. We hadn't done a quality check or anything to use it for that purpose, but we did. And you know, if you have an ultrasound picture, and you can look at it as an expert, you can also make a diagnosis. So it's about placing the probe where the patient is and connect with the internet, and then you have the picture where the expert is. And then you can say, yes, please hurry.
Yeah, and change this child's life. What about you, Dr. Mendez?
Well, you see, again, one of the issues that has been mentioned here is that how do you put the expertise where the expertise is needed? And with this tele-robotic system, and I remember very well, this was our first installment in a community that was 1,000 kilometers from our center. And it was a prenatal obstetrical ultrasound. And therefore, they found an ectopic pregnancy. And as you may know, an ectopic pregnancy can be life-threatening. And in that, basically, the identification of that problem saved this woman's life. And of course, there is many other examples, but that sticks on my mind because it was one of the first ones that we did, yes.
And for you, Dr. Lowery?
I remember a molar pregnancy that we had that showed up at the ER with bleeding, and they did a scan on her and made the diagnosis immediately, and they performed a DNC, and this would have been drug out for, like a month probably to get the patient scheduled into the university. And so it's just not something that people see commonly. I mean, I think these technologies allow us to match needs with resources in a more real-time fashion. Everybody's not going to be a maternal fetal medicine or a cardiologist or, even a radiologist for that matter. But they can work at their level. We can support them, and we can interact with them when necessary to speed things up, or in many cases, leave the patient in their local environment and manage them there. One of the things that we did in Arkansas when we were starting this stuff many years back is that we would co-manage patients with their local doctors so that the person didn't ever come to the university. That we manage them at home, like with growth restriction or diabetic management or these sort of things. So these technologies are not going to necessarily take the patients away, but we're going to help the local people better manage their complications in their home environment, which is what the patients want and what the hospitals want and really the local providers want.
So now all of you have seen firsthand the difference that Melody can make in the care for your patients. But I'm wondering, Dr. Olsen, but before you implemented this technology, I imagine that you did have some hesitations about it.
Yeah, I thought that it was, before I read these publications from Canada, which Dr. Mendez mentioned here in the opening, and I was worried about how to train the team on the other side, on the remote side. Would it be possible to achieve what I wanted from them in order to remove this robotic arm for me as an expert sitting in the expert site, in the hospital site. But it turned out that it was no concern, because the health providers working in distance from their local hospital, they are very much motivated to work together, to be in a team, to be a team member, to join in, because they work very often alone and isolated. So this was an opportunity to join a team, and they found it very satisfaction to cooperate even more, and in live setting, because we are connected in the same time. We are not collaborating about the patient talking in the phone, or I saw her yesterday, can you see her tomorrow? I'm worried about something. This is in real time, and we have the discussions right there. The same persons are hearing the whole discussions, the patients, her partner, the local person who is having the responsible for the further health care of that person, the pregnant woman from my experience, and me as a doctor, medical doctor, giving advice, telling what's going on. If you can see her in your office in 2 weeks, then we can do a new ultrasound in 4 weeks. So we all, as a team around the patient, are hearing the same thing. We are in the same discussion. It's like more like a seamless patient conversation. So and also those in the local community taking care of this patient, they learn from me as an expert. So it's a kind of an education bit in it also, because we talk in the same room all the time, though it's in a digital room.
I would just add to that, the patient gets to meet you prior to the transport as well. So it's not like a black box that the patient's traveling to. They can kind of get to know their providers in a tertiary care center. But I agree totally with you. When I started doing this stuff there was a doctor from South Africa that practiced in Arkansas, and I'd never met him in person, but we'd been doing consults and education things over video for a long time, and we finally had a meeting, but he was like my friend.
Yes.
I knew him, you know, as
Yeah.
opposed to, I mean,
Yeah.
you talk to somebody on the phone, but it's not this, I mean, the gestures that we use, or
Yeah.
everybody picks up on that. It's
And
a
this
way
is
of
something that it
communicating.
seems like we're going to go more in depth about the patient and provider relationship with Melody in just a minute. But I just want to establish first, would each of you say yes or no that today you have the same diagnostic confidence in remote ultrasound as you do in conventional ultrasound?
Yeah, you just mention the really two important things that Ingrid and Curtis have said. We have over the past 15 years worked on virtual care, not only with robotic ultrasonography, but other systems. And what we learned over these 15 years, that it's not about technology itself. It is about the building of relationships. It is about how the team and the remote team work together. It is about the building of capacity in the remote location, the education that Ingrid was saying. So, because technology will continue to evolve and change, but the building of these relationships will be maintained, and this is what provides sustainability over the long period of time. In terms of your specific questions, how does it compare with a traditional in-person ultrasonography? We've published 15 papers over the past 10 years on this comparison, and in our experience, robotic ultrasonography is very good for certain things and not others. So the technology has continued to evolve. Not all the patients that have tele-robotic ultrasonography will be completely diagnosed. A number of these individuals need to come to the centers to actually have a conventional ultrasound. We really envision tele-robotic ultrasonography at this time as a more first-line screening type of intervention. So I think it will continue to evolve, but there's still the need of conventional ultrasonography for sure.
So when would you say that remote ultrasound is not the right choice for a patient?
When you have anxious patients, you have to remember that ultrasound is just part of the consultation. The communication to build trust, to build in that you can trust on me and I am going to follow you. Maybe I am going to do an operation on you later on. You have to, in a way, you need to have meetings also in real, not only on a digital platform. But it's a very important tool to make the in-between controls, or the controls or the examinations or the situations, the diagnosis where you really do not expect to find something. Then it's perfect because you avoid this traveling.
Well, for the people viewing who maybe aren't as familiar with how the technology works, let's establish better how Melody works. AdEchoTech's technology, it's compatible with the ultrasound systems and machinery already being used in clinics and hospitals. So you do not have to go out and buy new ultrasound machines to use Melody. What is groundbreaking about this teleoperated innovation is that it allows essentially a virtual arm to become a virtual arm for doctors in another location. Dr. Olsen, I'm wondering if you can just explain what it feels like and what the process is like of using Melody as a provider.
Yeah, I will try. For me, I think on it as an ordinary consultations, but then it's two things that is different. The one thing is communication, because you have to be aware of that the communication on screen is different. The patient experience that different, and if you are in the same room, so you have to pay more attention to the communication part of it, and then it's the technology, and it's only in the beginning of when you are starting up the system, because you have to calibrate the probe. You have your assistants, another health provider at the remote side, and this person is holding, it has its hand on this robotic arm where the probe is placed. So this person needs to place the probe over the heart, over the fetus, over the kidney, and then you, on the expert side, you can then move the probe as you do in a normal ultrasound
Do you find that it
examination.
feels the same? The sensation?
Yeah, it's the same. You move the probe and you look at the screen, and you have this. This is the good picture. You freeze. You do your measurements. You move on. You do the next measurements. So it's in the beginning to have this technology and have this assistant to place the probe at the right place on the body of the patient. That's what's different, because you are rely on this helper in the remote.
So it has to
location.
be a really strong relationship.
Yeah, and also you have to, at least we experienced that we developed a special way of communication, because we are using the melody on fetus and they are moving. So we have to work fast. So for instance, if I want to see a 4-chamber picture of this fetus heart, and I say, oh, no, it's not perfect, but if you can move this, please, if you can move this 2 millimeters to the left and a little bit to up. You cannot have that long sentences, because then the fetus has moved. So you in a way, you have to agree on the communication for managing to a little bit left. Mm-hmm. What does it mean? So that's the way I experienced. You had to train your team to be good in communication, small communications in between, but also to the patients. Because as a gynecologist, as the expert, as the doctor, you're actually on the screen, on the wall. Mm-hmm. You are not in the room.
And Dr. Lowery, how do you compare Melody to traditional ultrasound when it comes to like the level of accuracy and working on all the same types of people, stages of pregnancy? Can you just explain that for our audience?
Well, there's definitely a learning curve to develop the technique for doing the scans, but once you develop that and working with the local team, there's really virtually no difference. We did a comparison of video ultrasonography to traditional, and it was exactly the same in terms, and there have been plenty of papers that have shown that you're going to miss things in both techniques, live or using the remote systems, but it's basically is accurate. If you think about it, what's the difference between looking at a screen in the same room or looking at a screen 100 miles away? There's really virtually no difference. Getting the imaging, the technique of driving the transducer is where the things lie in your head, right? It's 3-dimensional. You have to think in 3 dimensions of, orienting yourself of where the fetus is and then driving the transducer to get those images. And that's something that's really difficult to train people on. And, that's where, we've in the past relied on trained ultrasonographers to be able to do this. But guess what? Cardiologists need trained ultrasonographers, and radiologists need trained ultrasonographers. And there is a technique to this. And what you're doing is you're eliminating that necessity of having the people trained locally to be able to do those sort of things because it's residing in the remote center. And, you know, it takes longer to do these scans. There's no question about it, particularly when you're doing something like anatomic scans of the fetus. But when you look at the gains from this technology to be able to diagnose things sooner and manage the patients, you know, deciding who needs to be transported, who can stay there, and building the relationship with the local providers, it's worth the trade-off. And if you're putting the patient first, that's the way you got to think about it, right, ultimately.
Can you elaborate a little more on what the experience was like for your team learning how to use Melody? What some of the challenges were?
It's cumbersome in the beginning. Like, you know, you can control the gain settings on the device and make measurements on the device, and those sort of things are a little bit different than operating the device, you know, the ultrasound machine if you're in the same room. So you're having to learn that. You're having to learn to communicate with the local person, you know, that's they still have to move the head, right? You're having to move it because we have the wrist motion with the Melody system, but we don't have the elbow. And so the local people become the elbow. They're the ones that move the whole system up and down the patient or to the right and left. And so that's what you're having to communicate with the patient is you need to move up by 10 centimeters up on the mother's abdomen away from the symphysis pubis. And so depending on who you're working with locally, which can be, you know, a patient technician, or it can be a nurse or another doctor, theoretically, even in the whole thing. Each one of these have different requirements as to how much you have to direct them in what you're doing when you're using the system. So there's a learning curve, but it's tempered somewhat by the level of experience of the people that you're working with in the local environment.
I mean, I imagine, Dr. Mendez, there's been hesitation from team members with any new technology. Even the advent of computers was something that was difficult for some people in healthcare to adopt. But what were some of the challenges at the Virtual Health Hub?
Yeah, so one of the things that we did from the beginning is to really elaborate a comprehensive system for the deployment of this technology, not only in one site, but in multiple sites to really scale it up. So as part of this strategy, we put together a whole training program not only for the assistants that are in the remote sites. So we train these individuals, but also for the ultrasound technologists. And yeah, there's this learning curve. But in the learning curve, not only has to do with how you mechanically are moving the system, but this issue of communication is absolutely crucial. How do you communicate with the assistant that is on the other side that is actually holding the probe? So we have now a training program that includes the technologies that are actually performing the scan, the assistants that are assisting on the other side. We also have developed the whole logistics. Who orders the scan? Who does the scan? Who reports the scan? Where is the information going? So the logistics that support the deployment of this technology in the scaling up sometimes could be the most difficult barriers, all the way from individuals that do not want to see the technology used because they perceive that it could increase their workload. So, you know, there's a lot of these resistance there is. But the whole system, how do you bring the technology into the workflow of the remote community, the central community, Sometimes those are the most difficult barriers, and this is what we have been focused on, the virtual health hub.
So Dr. Olsen mentioned developing the shared vocabulary with the person on the other side. What would be your number one tip of how to help with the training or help with the communication?
I think the first thing is that everybody has to understand both the limits of the technology, the advantage of the technology, and how to work together. Usually the ultrasonographer that is related to the assistant on the other side that work frequently together, they develop their own language. They communicate with each other. And of course, the exam is much more effective.
It's not a do or die situation either. If you can't get the images that you need to get, bring the patient to you. That's one of the big mistakes I think people will make is think, oh, you can't do it, or bring them back on another day even. But I found that the obese patients are the biggest problem. With the obese patients, you often have to press pretty hard with the transducer to get adequate imaging, and so, but that's true of if you're doing it in the same room with the patient as well. Those are just difficult patients to image in general, but just bail out, you know.
Mm-hmm. I think that many viewers might be wondering, because each of you work with these remote populations, the question of connectivity with any kind of telemedicine. You're reliant on connectivity. Have any of you ever had issues because of technology limitations with using the technology?
Yeah, I experienced that in the very beginning, but then the internet improved, and after that it was not.
This was how many years ago?
Maybe 6 or 7 years ago. So, and after that, it has not been a problem. There is in the end of, because I've been working just in obstetrics and obstetrics ultrasound, and in the end of the pregnancy, the fetus head is very low down in the pelvic. And I had I think only one patient actually that I couldn't, because of the robotic arm and how the probe is fastened in it, I could not do the measurements. I could not. And for some patients we struggled, but we managed. And that's how it's how it's designed. I think that can be removed in the next version of the Melody robotic arm. So that's the only thing. And in my study, we compared traditional ultrasound and this Melody robotic study arm, and we didn't find any differences. We used 3 minutes in the Melody with the Melody operating system, but what's 3 minutes if you do not need to travel 3 hours forward and backward? So then 3 minutes, it's not important.
I'm pretty sure
Maybe
any
it's
patient would
important
choose
for the director or something. But the directors even have to pay for, in Norway, at least they have to pay for the travel costs as well. Mm-hmm. So I think that 3 minutes longer consultation is nothing.
Well, I want to ask more about the patients. What kind of reactions did you see from patients when they first encountered the Melody system and the remote ultrasound system?
Yeah, we have had, as I said, a lot of experience with virtual care. And what we encounter, not only in the Melody system, but in other systems as well, is that if you were going to receive care in your own community, with your own family, people don't want to necessarily travel. They want to receive care where they are, and they have the right. In Canada, the healthcare act says that every Canadian should receive the best care possible. But people that are in these locations don't, because they don't have the access to healthcare. So the acceptance of the patients are very high. You know, if you're receiving care and diagnosis where you are, people will accept that.
Have you found that even with populations like older people who maybe aren't traditionally as comfortable with remote technology?
Yeah, no, we have a lot of experience with older people, with indigenous populations. They are as accepted as any other one. There's not this issue of elderly people or specifically indigenous populations that do not like technology is a myth. People want to receive care in a timely fashion wherever they are in their own communities.
Yeah, I agree with that. I think people adapt to it. I personally told pregnant women that they have their fetus, their baby has a lethal anomaly and it's not going to survive, like anencephaly, for instance. The women have said that they like the idea of not having to travel. They were in their family to get the bad news. There wasn't a delay in telling them what was going to be done with the patient, because there's a great deal of anxiety, as you might imagine, if your local doctor says, oh, there's something wrong with your fetus, I want them to confirm it somewhere else, and then they're then left for the time to schedule at a tertiary care center before they're going to know the reality of the situation. So I really haven't found a lot of patients that reject the idea. I think maybe we're used to TV and videos and
Especially after
cell
COVID.
phones. Yeah.
Yeah. Have you noticed an improvement in the number of patients who are not missing as many appointments or discontinuing their care since this has been an option for them?
Yes, there are some persons that, for social reasons, may not take to travel to the hospital, and if they could not use this Melody system, there will be no ultrasound provided for them because they do not have the opportunity to travel.
Has that been the case have you seen that as well, that it's improved the amount of care or the quality of care that patients have gotten because they don't have to leave?
Oh, yes, absolutely. One of the things that, especially in the indigenous populations in Canada, the indigenous people say that, they're missing the cry of the newborn because a lot of the mothers were sent to urban centers to deliver. Now that I have access to prenatal ultrasonography, the number of deliveries in the communities themselves have increased. So that cry of the newborn has come back to the community. And that is an important cultural issue on top of or in addition to providing timely care.
I also want to add in, from my experience, those colleagues that is working at a remote location, after being familiar with using this ultrasound system, they feel more safe also when they are in work, in their ordinary work at a remote place, because they know that if something very special happens and it's bad weather and we cannot reach the hospital for several reasons, we have this system. We can connect, we can in minutes have my expert on the screen. So it's also for those colleagues and health providers working at a remote location, they feel a little bit safer.
And how does, because there's so much organization that you have to do between the hub and the spokes of all the many spokes, how do you make it work in terms of scheduling, patient follow-up? How does it work in terms of those logistics?
So yeah, as I was saying before, our approach has been kind of a comprehensive approach to developing the program that goes beyond the centralized operator of the ultrasound and the remote team. We really have looked at the issue of training, logistics, the issues of cost effectiveness, how much the capital, the installation of the system cost versus the cost of the traveling, which in Canada are huge from the north because a lot of these people have to travel by air. and even the carbon footprint, right? Decreasing traveling decreases carbon emissions and improves the environment. So we've taken this as a truly comprehensive program because our intention is to scale up. I truly believe that rural ultrasonography will use telerobotic systems. This is, I think, part of the future, and we're starting to build, those bases that to realize that future.
I totally agree, and that's also because the WHO, for instance, they have stated that it's a lack of health providers in the future. So, and you can have one expert site and several remote sites. So one expert can provide his or her expertise for several remote locations. And that's a way of, the English word, to meet the
Multiply
future,
or amplify
and to
the
meet the
effect, yeah.
future if with the lack of the health care providers, and especially in the remote areas, because you know already today that it's a recruitment problem.
The other thing you got to think about, the remote site, you probably aren't going to be able to fill them up with high-risk OB patients. But if you add now radiology patients and cardiology patients and other subspecialty groups, you can now fill up the scheduling for that system. And the control centers, you can have multiple control centers. So a radiologist can have a control center, an OB/GYN can have a control center, et cetera. So it's almost like the old-timey telephone system where you had, a telephone operator that would connect you to that patient. So you're dialing up these centers, and one control center can then jump from one unit to another unit to another unit to another unit, and even subspecialists can jump from unit to unit. So it becomes cost effective now.
Right. So we've talked about the cost savings of technology like Melody. Let's go deeper into the economics, because obviously that's a very important part of healthcare. Dr. Lowery, I know as an American that the healthcare landscape is extremely complicated in the US. What is the economic model for a solution like Melody there?
Well, I think I wish this was true in an altruistic world. It would be that we should just do it because it's the right thing for the patients. But that doesn't always happen in healthcare in America, mainly because it's driven by fee-for-service kind of approaches, which is, you do a procedure and you bill for it and you collect it. But as we begin to get into more hospital networks and we get into value-based care delivery, and within systems, now you're beginning to look at, can I save money? Can I do things that's more cost-effective to better bid contracts out? Well, that's the answer to this, is to use a system like this, because now you're not spending money, but you're, in a way, saving money by making more effective diagnosis and managing patients more effectively. If you're going to do care in rural areas, you really only have three options, right? You can send a doctor out there, you can send an ultrasonographer, or you can use one of these remote systems. That's your three options of doing this. And it's not cost effective to send doctors out because they're very expensive and they got a travel time, they're away from care delivery, and so that doesn't work. Ultrasonographers are an alternative to that, but we don't have enough of those either. And if you can't schedule like 5 or 6 patients in that center for that, even if you're sending ultrasonographers out, it's not cost effective. But again, in this approach, now we're jumping from center to center to center, so you're filling up a schedule of the ultrasonographer and an MD interpreting these things and to be able to talk to the patients. So it's kind of like you're using other people's clinics to increase your volume in a big way. So that's the way we got to really begin to look at this. You know, the remote people really want this technology a lot. So,
Dr. Mendez, I saw you both of you nodding a lot, but can you give us more specifics about the economic model for Canada?
Yeah, so as you know, Canada has a universal healthcare system. The payer is the government. And what's happening now is that the costs of healthcare continue to increase every year. You know, Canada spends about $400 billion in healthcare alone. But the quality of healthcare is continued to deteriorate. And we have this gap of healthcare workers. We don't have enough physicians. We don't have enough technologies. And it's very difficult to recruit these individuals to remote and rural locations. Just to give you an example, Indigenous Service Canada, which is the agency that provides the resources and the financing for Indigenous healthcare, spends in a population that is less than 200,000 people in the province of Saskatchewan, $116 million of for transportation alone. So, so the economic justification of that is very clear. It comes in my mind in two priorities. The first one always has to be the provision of timely care. So provide timely care in an effective fashion at a fraction of a cost of what it costs today, there is really not adopting that type of a system will become an ethical problem. So, both costs as well as the provision of timely care come hand in hand. And in our experience in Canada, the capital expenditures, the training, the setting up of a program, really when you look at the savings in 1 year, you could actually, for that community, buy 5 of these systems. So it's hard to argue that against a system that provides timely, effective care at a fraction of a cost.
And Dr. Olsen, what about the European
I have another view to add to this about the cost effective, because as a woman and thinking globally, I think that what is the cost of doing nothing for those women that we have heard Dr. Mendez and Dr. Curtis talking about? They do not have the option to go to an ultrasound or a health provider. So then they have to have a system that can meet them where they live. So if you have a woman and giving a fetus and you cannot discover that there is something wrong here, then how many life years do you lose if the fetus dies, or if it's born too early, or it's born with any sickness or something that also the healthcare need to take care of? That also has a cost. So it's not only about the money directly with giving the healthcare on the budget for everyone. It's also the human budget,
Right,
the
back
life
to the moral
year,
imperative.
yes, and the ethical issues and discussions. So again, we have the technique, we have this global situation that it's several people have not the equality healthcare that we sitting here have. So why not add plus them together and solve the problem?
Well, Dr. Mendez, you laid out how the cost savings, in your words, makes this an obvious choice. But is that the experience you've had when pitching remote technology and Melody to health authorities, to institutions? Like, how do they feel? How do you find that they feel in general about remote ultrasound technology?
Those are the real barriers. You know, the barriers are how do you introduce a technology that is effective as at the same time is cost effective. Governments and big institutions move very slowly. And in my experience and the experience of our team, the real basis for us to be successful in deploying this program in 7 locations in Canada has been the scientific basis. As I said, we've studied this. We published many papers on this. And that scientific basis is really important to convince the individuals that hold the purse strings to provide care, and also to convince our colleagues. We need to work on the basis of true evidence. And I think that has been the pathway that we have used. And so far it has been successful, but at the same time, it is a big barrier, and it's something that takes a lot of time and patience.
And Dr. Lowery, I mentioned at the beginning that you've worked with these big government institutions like Veterans Affairs in the US. Have you found that this is compelling technology to them, or what have you found the barriers to be?
Yeah. I mean, it's because like with the VA, like 2 transports saved justifies the purchase of the system. And when I've worked with politicians as well, the concept of putting equipment in their local districts and providing care there rather than in urban centers is very sellable to the system. In America, I think the biggest obstacle is just the financing and the payment. So we have to come up with ways of justifying this. And believe it or not, these are more about the urban centers, believe it or not, getting paid than the peripheral systems. If you're increasing the number of patients referred to you, then that's obvious a win situation. But in some of these other things, the payment isn't hugely great for the subspecialists. And so it takes time to do these technologies. And so, there's not so much of a yield in that traditional thinking. So there needs to be better ways of looking at value-based care payment for quality care issues rather than fee-for-service, which is still an impediment to changing a lot of the healthcare systems in America. But these things can be worked out. I mean, you can go to payers and demonstrate that the payers, the insurance companies and the government, they don't want to spend more money. I got news for you. They don't, and they're looking of ways of decreasing it. And what they're doing now in America is just decreasing fee for service. So each service you provide, you get paid less for it. So what do? You do more services then, but you can only do that. How many ultrasounds can you do in one day? Well, there's a limit to all this stuff. And then when you hit that, then you can't go any further. So we got to be thinking about this in a different way. We got to be paying people for doing quality things and putting the patient first and not volume.
Before we get to the Q&A, I want to just ask about what you see the future of this technology looking like. When you envision remote ultrasound in the next 5 to 10 years in Canada or worldwide, what do you see?
I think the technology is going to continue to evolve. I think that we are in this really special time on the evolution of technology, maybe unique in humankind with the advent of AI, robotics, computer technology, and telecommunications. So remote care and virtual care not only will go to remote and rural populations, but it will also go to urban populations because there's actually marginalized populations within a big city. An elderly people at home in a long-term care home, it is marginalized in terms of accessing healthcare. So these technologies will continue to evolve. In terms of specifically about telerobotic ultrasonography, there's going to be evolutions in terms of systems that may not need an assistant on the other side. They may be controlled by more complex robotic systems that have, for example, haptic feedback, where the individual that is doing the ultrasound will actually feel in the remote probe the pressure that they're putting in the abdomen of a patient. There's going to be interpretations by AI. eventually, as we go into the future, maybe the 10 or 20 years from here, there's going to be handheld devices that will be able to do an ultrasound. So, and it will be interpreted as well. So this is the natural evolution of this technology. And Melody and the system that we're using are really the initial steps of this technology. You can imagine when the first cell phone came, it was a big thing that you put on your shoulder and you have a hand, a receiver here. And imagine in a relatively short period of time, a cell phone has become this device that is the last thing that a person looks before they go to bed, and is the first thing that they look when they wake up. So this is going to be the evolution of remote systems and remote ultrasonography.
Dr. Lowery, as an early adopter of the technology, how do you view the future?
Well, this is producing a flat world, where everything's equal. I don't think that healthcare should be different. I think everybody ought to get equal health care. I mean, it's your health. I mean, hell, what else matters more than just your health? I mean, and in America, we have the highest maternal mortality rate of industrialized nations, and we're spending more money than anybody else. That ain't right. We got to do something different. If you're losing every game, you better change your team out. You better do something different, And I think that that's where we are now. These technologies in the past have been very ungodly expensive, but we all know that. I remember when I was in college, I bought a Hewlett-Packard calculator, and it could do square roots. And I remember, oh man, this is so great, because before you had to use slide rules, and it was just hard as hell. And think about that now compared to what we can do with these technologies. So this is inevitable. It's going to happen, and we can't afford to keep spending the kind of money we're spending on health care, and a lot of this is knowledge-based, right? So if you can make the knowledge available when the patients need it, wherever they are, you can begin to change. You're treating a disease not at the end of life, which is what we largely do now, but you're making a diagnosis earlier. You're moving the treatment paradigm up in the disease deterioration phase, and that makes a huge difference because it's easier to do something to prevent somebody from going into heart failure than it is to treat them when they're heart failure. Mm-hmm. And that's what we're doing here, whether it's obstetrics or cardiology or neurology. It's the same thing basically.
Dr. Olsen, hopes for the future?
Yeah, I think the future is bright for this telemedicine, and especially for Melody, I think, because it's already here, and we have this evidence-based results already. It's publicated, and I think that one of the barriers is that if we were doing this inside of a hospital, this development, this technical development, we would not have this discussion. Then we are so used to think that what's going on in the same building, in the same organization, that's improvement. But the new thing here is that we are working at remote locations and an expert location, and we are bringing in distances, and maybe we touch something that is in a way a barrier that is between urban and remote sites. And that's how we have to rethink of how we are thinking about providing healthcare and equality to remote locations. That's so simple for me, living in a remote area. I'm very familiar with those that argue that you are so few people, you take too much of the budget. So I think we just need to stop think that and add to the end, as we had in the discussion earlier.
Well, look at X-rays.
The distance.
Look at X-rays. I mean, it went from you got to have a radiologist here reading now to digital transfer, and they're all being read. I remember Nighthawks, the Nighthawk system, where they rotated the radiologist reading the scans around the world so that in the middle of the night it could be read in, you know, in Australia here. So think about that.
Yeah, so this technology, well, we might be in the early stage. It sounds like you all feel like this is the future of healthcare in many ways. Very well said. Now we'd like to hear from our audience. It's time for our Q&A portion. So our first question that's come in is, can the system or will it be capable to be used in cardiac sonography? Who would like to take that one?
Yeah, yeah.
Okay.
They just have to develop the technique just like in obstetrics. You know, the cardiologists need a special table to do their scans because access to the chest. But yeah, people are using it now for cardiology. So yeah.
Okay.
Yeah, yeah, yeah. They're doing echocardiograms, and I think there's been the initial work that was done in France was with echocardiography, and yeah, and it is more awkward, but it's something that will continue to develop because I think this is one of the great needs, echocardiography. And of course, you know, the individuals may not be the radiology technicians or the ultrasound technicians, maybe the cardiologists themselves that need to be trained. But yeah, there's been evidence that echocardiography could be used on the Melody system. Yeah.
Next question. Today, there are already very compact and portable imaging devices. What makes Melody different from those?
Yeah, maybe the critical issue here, there is something that's called, of course, point-of-care ultrasonography, you know, where you have devices that you have a physician that can use it, very small devices. It is really on the use case of remote communities where there's no expertise, there's no physician that's doing the point-of-care ultrasonography, that you don't have an ultrasound technologist. And this is the issue. You're bringing the expert that is in a centralized location to an area where you don't have the expertise to do the ultrasound. And I think this is what makes this system totally different.
Some more to add to that?
Yes, because as an obstetrician, I used to travel to these remote locations with a suitcase, and then I opened it, and then I was both the expert and the specialist, and I had my ultrasound machine in the suitcase. But with Melody, you don't need to travel. That's the whole point. And if you have a small device, handheld device, which we have already today, you need to connect to the specialist, to the expert, to have the right level of consultation. So that's the difference between the handheld local small devices that is already on the market. The whole point with Melody is that it's you have the same level of quality with the person doing the ultrasound, the expert.
Okay, next question. Someone wants to know more about the onboarding process and is asking, was the adoption by local teams, did you find it to be quick?
I don't know about quick. I think there's a learning curve with it, but you have to have somebody committed to working with you. That's for sure. You know, but if you do that, then they adopt it. I mean, they want to keep the patient there, and in many ways, the clinic or the hospital wants to keep the patient there. So as long as you have a team that's committed, now you do have to train everybody. You change out the team, and you have to retrain them, or they have to be trained to do that. And there is, like anything else we do in healthcare, proficiency. The more of these things you do, the better you get at doing it. You know, if you do one surgical case a year, you're not as good as if you're doing, 20 or 30. So that's the way you got to remember this. So,
In my project, it took a year.
A year.
Yeah, a year.
I'm wondering, because now you have said that you have a pretty well-oiled machine.
Yes.
How have you found from like the initial teams who first learned to now that you do have a protocol, has it become much quicker, the adoption?
Yes, it is organized. The adoption then becomes organized. Once you have a training protocol, you train both the ultrasound technologies as well as the remote team. The adoption has become easier, more straightforward. But something that is really, really important, and what Curtis was saying, is that to provide care to these remote and rural locations, you need to have the commitment that you want to do that. That hasn't changed. That is still a crucial element. And this is something that we promote as we are expanding the number of sites that we have. So that commitment to provide service
You have
is important.
you have to do enough volume to be proficient, and if you're not getting enough patients out of that site, you need to do some kind of like fake patient or bring in a patient to do the scans, because otherwise it decays. You can't do like one of these things a month or something and be proficient at it. The machines will be unplugged and everything else. So you have to be doing enough of a volume, and if you have 2 or 3 sites that are relatively near one another, shut some of them down and move them to one place so that they're able to maintain proficiency. Or you're going to have to do some kind of, like I said, dummy patient periodically to bring them in so that
Volunteers.
volunteer. Yeah. So it's a dummy, but volunteer would be a better word.
Yeah. You need to keep the skills of the team. In our experience, the volume continues to grow. We do more than 1,000 patients now a year. So the sites have to be active. They have to continue to do that. And then you develop a routine. And once you establish the routine, then I think the system works very well.
I agree. When we started out, from my experience, we didn't have this program. We had to design it, the training program. So it was also a debate and a discussion in the team. Is this sufficient? Shall we do something else? So in a way, we also we both trained, but we also developed a training program. So it was 2 issues going on.
Well, you guys are blazing this trail, because anyone who adopts this technology after you will be able to learn.
It will be easier.
It will be much easier for them.
Let me just say one thing. The technology's cheap. It's the personnel that's the cost. And you'd be better off to buy the technology and send people to that site if necessary, like nurses or patient tech people, because you want to have somebody that can work with you ultimately at that local site. That's crucial.
Final question from our audience, who wants to know more about Melody's use in emergency situations and how you integrate that into daily practice to handle emergency situations.
So as any technology evolves through phases. At this point of the evolution of the system, at least in our hands, we do all elective cases. As we are building this virtual health hub, which will be a purposely designed building that will contain 15 centralized control centers, we will expand this from an elective procedure to responding to emergencies. So we'll see how the experience goes, but it makes sense that if you already have established a program, you have the team, both the central team and the remote team, you're doing elective cases, you have conquered the learning curve, then the next logical iteration will be, if you need an acute ultrasonography system for a patient in an emergency, it is the next logical step. And this is something that we will continue to evolve.
We did something in Arkansas with the telestroke program, a virtual telestroke program, and we put it in all the emergency rooms. So with Melanie, it's going to be a while before you get to that. But we had a call center. We trained the EDs to be able to diagnose the symptoms of stroke and to get the proper imaging, and then brought a neurologist in to interpret the imaging and decide whether to give TPA or not. I think it'll be like that, right? So you'll put the system in the ED, train the people to use it. You'll maybe do simulations periodically to maintain proficiency of those. But then when you have a patient that come in that you need to do a cardiac scan on, the people will be able to do that, and a cardiologist then can, make a diagnosis and help manage the patient. So it'll evolve to be something like that,
All right. Well, what we've learned and established today is that remote robotic ultrasound, this is not an idea for the future. This is technology that is already changing how care can be delivered for remote and underserved communities, especially Melody equals easier access to care, less cost, and less stress. And remember, this technology, it does not replace doctors. It extends their reach and allowing expertise to travel where it's really needed most. I want to sincerely thank each of you for coming all the way to France and joining us for this conversation. Dr. Olsen, Dr. Mendez, Dr. Lowery, really appreciate your time.
Thanks for having us.
And we'd like you to stay connected. So follow AdEchoTech on social media, on LinkedIn, so that you can be sure to get announcements and updates. And of course, if you believe that Melody is a system that can help you or your organization extend your reach and help care for more patients, please get in touch with a member of the AdEchoTech team. Thank you again for joining us for this really important conversation. Thank you so much, everyone.
Thank you.
Thank you.